The key to patient care is proper diagnosis. In order to couple the symptoms of illness as described by the patient with the signs or findings on physical examination, a knowledge of anatomy, and particularly the relationship of structures to one another, is essential. Proper examination of the abdomen requires an understanding of the structure and function of the abdominal wall, its innervation, and the relationships of underlying viscera. Dr. Snell will demonstrate abdominal landmarks and discuss the anatomy of the abdominal wall, and I shall demonstrate the application of such knowledge in selected patients. Dr. Snell.
One of the first things that one must be sure is that the patient is completely relaxed by having the arms down by the side, and then to generally just talk with him and ask him to breathe gently in and out. Would you do that for me? Just breathe gently in and out. Fine. One of the first bony points that we should find is the manubriosternal joint. This is found by running down the fingers down the front of the sternum until you come to a ridge. Opposite the ridge is the second costal cartilage, and from there on downwards we can count the costal cartilages without having to either count up the costal cartilages from below or attempt to count them down from above. It's important to remember that the manubriosternal junction is opposite the disc between T4 and 5 thoracic vertebrae. The next point I think that's useful is the xiphisternal joint, which is down here. You run your fingers down the front of the sternum, and there is a depression at the lower end of the sternum where the fingers drop off from the body of the sternum onto the xiphoid process. And here the level is at about the level of the 9th thoracic vertebra. Now from that point onwards we can follow the costal margin down on either side. And this is the infrasternal angle or subcostal angle, and the Lurs margin here is formed by the 10th costal cartilage. Now I think a physician should realize that the anterior abdominal wall just doesn't consist of the soft underbelly down here, but must realize that the abdominal cavity extends up under the thoracic cage to the level of the diaphragm. Now the central tendon of the diaphragm lies at the level of the xiphisternal junction. The right cupola arches up to the level of the upper border of the 5th rib, and on the left side to the lower border of the 5th rib. The reason for the right cupola being higher is because of the larger size of the right lobe of the liver. I think we should now mark in the costal margin. We start up here at the xiphoid process, and we come round the costal margin to its lower limit, which is the level of the 10th costal cartilage. And we do the same on the other side, coming round to the 10th costal cartilage. And then we put in here the xiphoid process. The groove that we can see down the midline here, the slight groove or depression, overlays the underlying linear elbow. The umbilicus is variable in position, but usually lies approximately in front of the 3rd lumbar vertebra. Now as we come down to the lower part of the anterior abdominal wall, we should palpate the full length of the iliac crests on each side, starting at the back here at the highest point and then passing forward. And we notice that the iliac crests end in front at the level of the anterior superior iliac spine. And I'll just indicate the position of these spines on each side in that manner. Now towards the midline, we can palpate down to the upper margin of the symphysis pubis. That is the cartilaginous joint between the two pubic bones. And if we were to invaginate the scrotum with a little finger, we should be able to feel the pubic tubercle. Now running between the anterior superior iliac spine and the pubic tubercle is the important inguinal ligament, which is the curved lower margin of the aponeurosis of the external oblique. And I'll merely indicate the position of this ligament in this manner. So that here we have then the anterior abdominal wall, extending down to the pelvis and above, beyond the costal margin, to the level of the lower border of the 5th rib on this side and the upper border of the fifth rib on this side. So that the abdominal cavity is protected to some extent by the ribs and the intercostal muscles and the diaphragm, whereas below here the soft underbelly just has the muscles of the abdominal wall protecting the viscera. Now if we ask this patient to gently raise his shoulders without using his arms, we can make out the lateral margin of the rectus abdominis muscle, and I'll just indicate that in this fashion. It runs from the costal margin down to the pubic tubercle on both sides. Thank you. And where this line, which is referred to as the linea seminularis, where this crosses the costal margin is the tip of the ninth costal cartilage, and this is an important landmark. Now if we're going to localize abdominal structures and be able to communicate with our colleagues, it is essential that we divide up the abdominal cavity into zones or regions. And to conveniently do this, we use these bony landmarks that we have discussed. First of all, we use the subcostal plane. Now the subcostal plane runs across the abdomen from one 10th costal cartilage to another. And this lies at the level of about the upper border of the third lumbar vertebra. Then we come down to below to the iliac crest, and if you palpate the iliac crest on its outer surface and run it back for about 2 inches, you can feel a prominent tubercle, the iliac tubercle. And if we connect these tubercles across the midline in this fashion, we form the intertubercular plane, which lies at the level of the fifth lumbar vertebra. I think we should put in the right and left vertical planes. These planes arise vertically from the midpoint of the inguinal region. Now when we say the midpoint of the inguinal region, we are referring to the midpoint between the anterior superior iliac spine and the midline. Now if we take the midpoint is there and put a vertical line in, and I'll interrupt it so as not to confuse it with the linea seminularis, on either side. So that then we have 2 horizontal planes, the subcostal plane, which lies at the level of the body of the third lumbar vertebra, the transtubercular or intertubercular plane, which lies at the level of the fifth lumbar vertebra, and the right and left vertical planes. This enables us to divide up the abdomen into regions. The epigastric region being here between the costal margin and the subcostal plane there, the umbilical region here, and the hypogastric region there. And then on either side we have the hypochondriac regions, the lumbar regions, and the iliac regions. This means we can say the stomach lies in the epigastric region. The spleen here lies along the 9th, 10th, and 11th ribs in the left hypochondrium. The appendix lies in this region here, in the right iliac fossa, or right iliac region. The ascending colon here lies in the right lumbar region. Now, while we are talking about these planes and regions, I think it is worth noting 2 other horizontal planes that are commonly used clinically. The first is the transpyloric plane. And the transpyloric plane runs across at the level of the tip of the 9th costal cartilage. Now we don't have to bother to count down the cartilages. All we have to do is again ask the patient to raise his shoulders so we can feel the lateral margin of the rectus, in other words the linea seminularis, and where this crosses the costal margin, we know that to be the tip of the 9th costal cartilage. And this lies at the level of the first lumbar vertebra. So this is the transpyloric plane going across here. When we say transpyloric, it infers that it goes through the pylorus, but I might remind you that it goes through the duodenojejunal junction, it goes through the neck of the pancreas, and it goes through the hilar of both kidneys on either side. It's a useful clinical plane. Now down here we have another plane called the intercristal plane, and this runs between the highest points of the iliac crests, and we can indicate it here in this fashion, running across. And this lies, you notice, above the intertubercular plane. The intertubercular plane is opposite the body of the fifth lumbar vertebra, and the intercristal plane lies opposite the body of the fourth lumbar vertebra. Now, can we mark on the anterior abdominal wall the viscera contained within the abdominal cavity? The answer is we can, but of course the position varies from one individual to another, and in the same individual from one time to another, depending on the contents of the stomach, for example, and the contents of the gut, and whether the person is in the vertical position or the horizontal position. But there are certain organs, such as the gallbladder and the liver, which we can mark in because they're fairly constant in position. Now, the fundus of the gallbladder comes in contact with the anterior abdominal wall opposite the tip of the right ninth costal cartilage. In other words, where the linea seminolaris crosses the costal margin. And I'll just indicate the position there of the gallbladder. Now, quite clearly, as the patient takes a deep breath and the diaphragm descends and the liver descends with it, the fundus of the gallbladder would come down and would impinge upon the examining fingers. Now we can place in the position of the liver. In the adult, the liver, the lower margin of the liver, in a well-developed individual with thick abdominal muscles, well-developed muscles, is difficult to palpate. But in a thin individual with fairly thin muscles, if you ask the patient to take a deep breath, would you take a deep breath, you can feel the lower margin of the liver come down. It's just about a finger's breadth beneath the costal margin. And I'll indicate its position in that manner there, coming down the gallbladder, just projecting or just at the level of the lower margin of the gallbladder there. The kidneys are lying on the posterior abdominal wall. The left kidney is high up because of the small left lobe of the liver, and the right kidney tends to be lower because of the large size of the right lobe of the liver. The only kidney that can be felt, which is normal, is the right kidney. And here you put your hand behind the patient's back, you put your hand in front here, and you ask him to take a deep breath. Breathe in, and if the person has a thin abdominal musculature, you can very often feel the lower pole of the right kidney coming down between the examining hands. On this side, it is impossible to feel the normal right kidney, the left kidney. The spleen cannot be palpated through the anterior abdominal wall in the adult. In the newborn baby, the lower pole of the spleen often can be just palpated at the level of the subcostal margin.
Starting to talk about the differential diagnosis of different abdominal pain, I'd like to remind you of the 9 regions of the abdomen. To start with, we're going to have the right hypochondriac region, then the epigastric region. After that is the left hypochondriac region. Below comes the right lumbar region, the umbilical region, and the left lumbar region. Then the right iliac region, the hypogastric region, and the left iliac region. Now, I found this picture online that basically summarizes the differential diagnosis of different abdominal pains regarding to the quadrants. So I'm going to go through them quickly and then give you a very simple way of how to memorize the different regions and the different causes of pain in every single region. So we're going to start with the right hypochondriac region. It's going to have gallstones because normally the gallbladder is going to be present in this area. You're going to have stomach ulcers and pancreatitis because the head of the pancreas is in this area. Here you're going to have anatomically the esophagus and the stomach. Therefore, stomach ulcers are common to be present as pain in this area, which is the epigastric region, and the heartburn or indigestion, because as we know that as long as the esophagus and the stomach, both of them lie anatomically in this region, then whenever there's going to be gastric reflux of acids into the esophagus, it's going to be present as heartburn in this area. pancreatitis because the pancreas is present in this area, and epigastric hernia because this is going to be called the epigastric region. Left hypochondric region, the patient is going to be present with stomach ulcers and duodenal ulcers because here is usually a part of the stomach is present. Biliary colic and pancreatitis because here the tail of the pancreas is present. Below that comes the right lumbar region. We have kidney stones because at the posterior part we're going to have the right kidney. We're going to have also the ascending colon and the small intestine in this area, which is the right lumbar region. Therefore, constipation is going to be a complaint of pain in this area sometimes. We might have lumbar hernia because this is the lumbar region, and we might have urine infection. In this area, we're going to have pancreatitis, stomach ulcers, inflammatory bowel, and small bowel disease and umbilical hernia because this is the area where the umbilicus is. But I'd like to remind you that we're going to have early appendicitis in this area. The patient who has early appendicitis is going to be present with pain around the umbilical region. But that doesn't mean that the appendix lies here, which is the umbilical region. No, the appendix lies in this region, which is the right iliac region. But usually early appendicitis pain is going to be present with pain around the umbilicus. Then we come to the left lumbar region. We're going to have kidney stones because the left kidney is present here, diverticular disease because this is the area where we're going to have descending colon and small intestine, constipation and inflammatory bowel disease. Proceeding downward to the right iliac region, as we already mentioned, the appendix is going to lie in this region. Therefore, the patient with appendicitis in a later stage might present with pain in this region. Constipation, pelvic pain, which is most probably due to gynecological reasons, especially in women, because in this area we're going to find the right ovary and the right fallopian tube, and it might be Crohn's pain because of inguinal hernia. After that, we're going to come to this area, which is the hypogastric region. In this area, we're going to have the urinary bladder and the ureters and the sigmoid colon, the rectum, and also the fallopian tubes are going to start to emerge from this area, as well as the uterus, which is going to be lying in this area. Therefore, we can conclude because we have the sigmoid colon and the rectum, we might have diverticular diseases. Urine infection can happen because here we're going to have the urinary bladder and the ureters. On the other hand, pelvic pain, which is due to gynecological reasons, might also happen because we have the uterus here together with the fallopian tubes. In this area, we're also going to have diverticular diseases, pelvic pain, and Crohn's pain. Now, I know that all these diseases that I already mentioned and the pain reasons and everything might seem a bit confusing and might be a bit hard to learn, even if you actually know the anatomical position of every single structure. Sometimes the pain might be referred to other pain. Therefore, I concluded a very easy way to learn the different differential diagnosis of the abdominal pain according to the quadrants. Now, this scheme basically is going to be representing the quadrants as I represented them in the first slide of mine. This is going to be the right region and this is going to be the left region. So this is the right hypochondric region, epigastric region, left hypochondric region, right lumbar region, umbilical region, and left lumbar region. And here we're going to have the right iliac region, the hypogastric region, and the left iliac region. So, to start with, the right hypochondric region is going to be presented with a word called GUS. What does GUS stand for? The G in the GUS is going to stand for gallstones, and the US is going to stand for ulcers in the stomach. The epigastric region is going to have a hug in it, and it's going to be presented as, because it's the second region we're going to be talking about, so the H is going to be presented in two differential diagnosis. The first one is the heartburn, and the second one is the epigastric hernia. So the second one is hernia and the epigastric because it's called the epigastric region. The U is going to stand for stomach ulcers, and the G is going to stand for gallstones. After that, the left hypochondric region is going to be symbolized too as BUDS. BUD is going to stand for biliary colic, then ulcers in the duodenum and the stomach. Now, do you notice that we forgot something really important? Because we mentioned that the head of the pancreas is going to be here, the pancreas is going to be here, and the tail of the pancreas is going to be in this region. Therefore, we're going to have to add 3 P's in all these regions. To learn it in an easy way, we're going to say that this region is going to be symbolized by a sentence called Gus hugs buds. So Gus, who's a guy, is going to hug his buds together with 3 B's in all the region because we're going to have a pancreas. Easy, right? Okay, proceeding to the next region, we're going to have chest, which is a name of a guy. C is going to stand for constipation, H is going to stand for hernia, and because we are in the lumbar region, so the hernia is going to be a lumbar hernia. I is going to stand for infection in the urine, and S is going to stand for stones. Where the stones are going to be? We're already in the right lumbar region, so the stones are most probably to be in the kidney. After that, we're going to have a word called abuse, which is going to represent the umbilical region. In abuse, A is going to stand for appendicitis, which we have already discussed. B is going to stand for inflammatory bowel disease, and U is going to stand for ulcers. Where are the ulcers? They are in the stomach. That's why we have an S after the U. And the E here is to remind you that the appendicitis course, when it's going to present in this pain, is going to be early. And the left lumbar region is going to be presented as a disc, and the disc is going to stand for diverticular disease. I is for inflammatory bowel disease. S is going to be for the stones that are going to be in the kidney, and C is going to be for constipation. Okay, so the sentence here is that Chris, which is a guy, has abused his disc or misused his disc. And you have to remember that here we had 3 P's, here we only have 1 P, which is going to be in the umbilical region, because pancreatitis can be represented as pain in this region. So the sentence for the second part is Chris abused disc. The last part we're going to be talking about is this part. To start with the right iliac region. In the right iliac region, we are going to have a cap. What would CAP stand for? C is going to stand for constipation. A is going to stand for appendicitis, because the appendix is usually present in this region. And the P is going to stand for the pelvic pain, which we already discussed could be due to gynecological reasons, because the right fallopian tube and the right ovary is going to be present in this region. But we forgot one thing, which is the inguinal hernia, which might be presented as Crohn's pain. So it's CAP and I. CAP is my friend and it's me, so it's CAP and I. The next region is going to be the hypogastric region, and it's going to be presented with a paid, the verb paid. P is going to be standing for pelvic pain, which we already talked about, and the A is going to be standing for appendicitis. The I is going to be standing for inflammatory disease, and the D is going to be standing for the diverticular disease, which we said is normal because we have the sigmoid, colon, and the rectum in this region. The last region we're going to be talking about is the left iliac region. But before I forgot, something about the hypogastric region you have to keep in mind, that sometimes the urine infection is going to be present in pain in the hypogastric region, because we're going to have our urinary bladder and ureters in this region. So it's paid U. Then the last region, which is the left iliac region, which is going to be presented as DIP, dip. D is going to stand for diverticular disease, I is going to stand for inguinal hernia, which is going to be presented as Crohn's pain, and pelvic pain, which is going to be presented due to gynecological problems, as I already mentioned. So what's the sentence for the last part? It's CAP and I paid you dip. So we put a dip for CAP, and it's me and CAP who paid for it. So the 3 sentences that are going to help us to learn the differential diagnosis of different abdominal pains are going to be Gus hug buds, chest abuse disc, and cap and eye, pay, due, and dip. I know that it might seem a bit funny at first, but trust me, it's really helpful if you're trying to learn the differential diagnosis of abdominal pains for the first time. And then after that, you could relate it really easily, because after that, with practice, you could learn these abdominal differential diagnosis of different abdominal pains in a more easy way.
Hi, my name is Adam. I'm one of the final year medical students. Can I ask your name?
Dan Stage.
Hi Dan. I've come to do an examination of your tummy today. So I'll have a look at your hands, have a look at your face, and then have a press on your tummy as well. Would that be okay?
Yeah, that's fine.
Great. Would you mind taking your t-shirt off to begin?
Yeah, of course.
Okay Dan, I'm just going to have a look at you from the end of the bed. Could you put your hands down by your sides? Okay, I'm just going to have a look at your hands, Dan. So if you could put your arms out for me like this. And if you put your two index fingernails together like that. That's great. And if you turn your hands over. If you turn your hands over again, extend your wrists all the way back and close your eyes. That's great, thanks Dan. And if you could raise your arms up for me. Okay, you can put your arms back down. Okay Dan, I'm just going to have a look at your face, so if you just look straight ahead for me. And if you could pull your lower eyelid down with your finger. That's great, and if you look up at the same time. Okay, that's brilliant. You can stop doing that, and if you open your mouth and stick your tongue out and point it up in the air. That's fine, you can close your mouth, thanks. I'm just going to have a feel around your neck. I'm just going to have a feel of your tummy if that's alright now, Dan. Have you got any pain anywhere?
No.
No. I'm just going to flatten the bed. Are you okay lying down flat?
Yep.
Okay, I'm just going to have a feel of your tummy now, Dan. Tell me if you're in any pain. And I'm just going to press a little bit deeper this time. Can you take some deep breaths in and out for me now, Dan? That's great, and keep going. just going to feel the blood vessel in your tummy. I'm just going to tap on your abdomen. If you roll over towards me. That's fine, you can line your back again. I'm going to have a listen to your tummy now, Dan. Okay, Dan, that's the end of the examination. Thank you. You can get dressed again now. Thank you. In summary, I examined Dan, who was a 28-year-old male. He had no peripheral stigmata of GI pathology. His abdomen was soft and non-tender. There was no organomegaly and bowel sounds were present. This is consistent with a normal GI examination. To complete the examination, I would examine external genitalia, hernial orifices, and do a PR examination.